And the most okay. And the most familiar form of allergy are asthma, atopic dermatitis, or eczema. They are most often the reason for clinical visits, referrals to allergists aside from drug allergy and urticaria. When atopic people are exposed to allergens, they can develop an immune reaction that leads to allergic inflammation. Allergy may manifest in different children or adults in different ways. So for example, on our patients, allergy manifested in the nose and or eyes, resulting in allergic rhinitis and or conjunctivitis. The second case, the skin resulting in atopic dermatitis or eczema or urticaria. And lastly, some allergies will manifest in the respiratory system, resulting in bronchial asthma. So how does an allergic reaction happen? Probably this is one of the most common questions. When an allergen here, such as the pollen or food, such as the peanut or the dust mites, enters the body, it triggers an allergic or an antibody response. When the antibodies attach themselves to the mast cells, it will come into contact with the antibodies, and the mast cells respond by releasing histamine. So let us just focus our attention with the histamine. With the release of histamine due to the allergen, there will be a resulting inflammation or an allergic reaction. And this allergic reaction is very irritating and uncomfortable to the patient. People experience different symptoms depending on the allergen and where it enters the body. Allergic reactions can involve many parts of the body all at the same time. There may be a lot of questions regarding asthma and allergy that most of you parents here or the school staff must have wanted to ask their pediatricians or allergists but did not get a chance to ask. Some of the questions may be the following. Who gets asthma and allergy? When does it start? Is it a chronic disease? Why do some people have allergy and some do not? And what are the different signs and symptoms? And does it ever go away? Okay. One important part of the history taking that pediatric allergists as the parents or the guardians of children brought to us for consult is that, is there a family history of allergy? So who amongst the parents or the couples out here? So let us have a test. If both parents have no allergies, so here, no allergies in the family, or with one family member or one parent with an allergy, two family members with the same allergy, or two family members with a different allergy. Let us see whose couple or whose children will be more at risk of developing allergy. Okay. So here, no allergies in the family. The infant is low risk, or the child is low risk of developing allergy. But if one family member has an allergy, there is an increased risk. Two family members, high risk. And if two family members with the same allergy, the child or the infant has the highest risk of developing allergy. So here. So the infant whose family has no allergies, 5 to 10%. On the other hand, one family member with allergy, 20 to 40%, high risk for two family members with an allergy, and the child with both parents are atopic or allergic with the same allergy, 60 to 80%. Okay. Next. Allergy can manifest in children in different ways. This is what we call the atopic march. It refers to the natural history of allergic diseases as they develop from infancy and childhood. Importantly, the presence of one allergic condition increases the risk for the development of others, resulting into the additive feature of the atopic march. Classically, when we say atopic march, it begins with atopic dermatitis during the initial phase or during when the patient is still a baby, and progresses into food allergy, then into asthma, then into allergic rhinitis. However, I must mention that it is important to note that not every atopic dermatitis patient will develop asthma, and not every patient with asthma has a preceding atopic dermatitis. Okay, so let us discuss briefly one by one. So here, this is a classic example of a patient with atopic dermatitis presenting to our clinic for initial consult. This is a common picture of patients that we see. From here, the patient has ill-defined patches over here on the cheeks with scaling and erosions. If you can see here, the scalp has greasy, yellowish, greasy scaling. So this is what we call as a typical picture of a patient or an infant with atopic dermatitis. Atopic dermatitis typically manifests in early childhood with onset before 5 years of age in approximately 90% of patients. We often classify rash of these patients as acute or chronic with a cutoff of 6 weeks duration. Therefore, from the looks of our patient, there's already lichenification, excoriation. This must be a chronic case of acute dermatitis. Atopic dermatitis has no pathognomonic skin lesions. Diagnosis is based on the presence of clinical features. During infancy, there is what we call as the dermatological distribution of the skin lesions per age. So here in this patient, as you can see, atopic dermatitis during infancy involves primarily the face, the scalp, and the extensor surfaces of the extremities. So here, ito. And then the diaper area is usually spared, but if it is involved, usually it is associated with the candida or the fungal species. In older patients, among the children and then the adolescents, the flexural folds of the extremities are the predominant location of the lesions. And most especially, one thing that is very common among these patients with atopic dermatitis is that the presence of pruritus is critical to the diagnosis. So they would always say, or the patients would always observe that the children or the infant is scratching. And patients with atopic dermatitis have a reduced threshold for pruritus. Aside from the genetic family history, is the environmental setup of the patients also affects the predisposition to develop allergy or atopic dermatitis. In allergy, we call that the hygiene hypothesis. Increased exposure to pollutants and interallergens, especially your dust mites, and a decline in breastfeeding is suggested as a reason for increased frequency of atopic dermatitis. Atopic dermatitis is more prevalent in the higher socioeconomic class, those living in the urban areas, and those patients whose parents or those guardians which has a higher education level. We probably attribute it to the increased awareness of the parents or the guardians. However, the ultimate presentation of an atopic disease may depend on the interaction between the environmental exposure as well as the genetics of the patient. Atopic dermatitis is a clinical diagnosis. However, depending on the severity of infection, we request for the usual laboratories such as your CBC, your stool analysis, or whatever is needed for the patient. Sometimes, pediatricians will refer to an allergist for skin prick test. This is what we call as the skin test. If they are suspecting it is associated with food. Okay, so as you can see here, this baby is having a prick or a skin prick test. There is already a wheal and a flare result from the prick test, meaning this patient has a positive reaction to the skin test. How do we treat now, or how do we manage atopic dermatitis? In the treatment of atopic dermatitis, patients and caregivers must understand that the therapy is not curative. So it is symptomatic. but that the avoidance of the exacerbating factors together with the proper daily skincare can control the symptoms and improve long-term outcome. Therefore, the cornerstone in the pharmacological treatment or management of atopic dermatitis are the use of your anti-inflammatory, the use of your antipruritics, as what I have mentioned. These patients always itch, they always scratch, and they have a low threshold for itch. The use of your antibiotics when there is already the presence of infection, and most especially the use of your emollients or your moisturization. So this is the cornerstone or what we use as a baseline for the treatment of patients with atopic dermatitis. I want also to emphasize on the use of your steroids because some of the patients, some of the parents are prone to using steroids over the counter. Most of us allergists always emphasize that the use of your topical corticosteroids must be according to the age of the patient, must be according also to the severity of the lesions. Here, I will teach you how to use or what to look at on the type of steroid that you are using. Look at the class of the steroid and not on the percentage. So the steroid strength is classified whether it is a super high, medium, or low, because the potency will produce the type of side effect that will happen to your child or to your son or to your child. Okay, sorry about that. So let us see here. Clobetasol is classified as super high corticosteroid. Clobetasol 0.005%. If you will compare it with your hydrocortisone ointment, which is 1%, it is classified as a low potent corticosteroid. So therefore, it will produce lesser side effects as compared to your super high or most potent corticosteroid. Why do we want to emphasize on the side effects? Because local side effects of your steroids will include skin atrophy, telangiectasia, striae. It will also cause acne or an allergic contact dermatitis. And the most common, this is one I usually observe this on the clinic whenever parents will treat their child on their own, hypopigmentation. So they would end up looking like para silang Dalmatian, pero opposite. Okay? So that is why we always emphasize on the type or the correct usage of your corticosteroids. Okay. Next, let us go to the most popular form of allergy. It is one of the more popular form of allergy, which is allergic rhinitis. In the study done by fellow allergists, Dr. Abong, Dr. Kwong, Dr. Castor, and Dr. De Leon, they found out that 20% of Filipinos have allergic rhinitis, which I definitely agree. Not just adults, but in the study of Dr. Kuwa Lim, which we consider as the mother of our society, Pisay, allergic rhinitis is also prevalent among Filipino children. I'm sure the school physicians at Ateneo would have observed this that allergic rhinitis is common among their students. Okay. Allergic rhinitis affects 10 to 30% of adults and 40% of children. There is an increased economic burden on patients with allergic rhinitis. Why? Because it can cause loss of work and school days and decreased work productivity. So we commonly observe absenteeism or presenteeism among patients with allergic rhinitis. And also with physical signs, so in the of life of these patients with allergic rhinitis are decreased. You would often see them with disturbed sleep, daytime somnolence, and fatigue. They are sometimes irritable, depressed. There's also the impairment of physical and social functioning. So that is what we observe among patients with allergic rhinitis. How do we know that our child or us have allergic rhinitis? Okay, so let us see. So here, these are the physical signs of allergic rhinitis. It includes the Denny-Morgan folds. So you can see here the eyes of the patient. Sometimes there are folds below the eyes or the skin below the fold below the eyes of the patient. Sometimes I would say, or the parents would ask, Doktora, para kasing laging puyat yung anak ko, maitim yung ilalim ng mata. So as for the Asians, we sometimes see it as puyat yung mga anak natin or maitim yung ilalim ng mata. And then there's also the behavioral signs. In order to relieve the irritation or the flow of mucus, patients would often or habitually rub their nose upward. So pag ganon. Okay. So by habit, so they would rub their eyes. So they would rub their nose. And what happens? And that is what we call as an allergic salute. And because of the habitual allergic salute, it results into a crease running transversely across the nose. So that is what we call now as your transverse nasal crease. So those are the common physical signs of patients with allergic rhinitis. Okay. So the diagnosis of allergic rhinitis is strongly considered in the presence of symptoms: sneezing, rhinorrhea, nasal congestion or obstruction, and it is triggered by allergen exposure. It may be associated with conjunctival redness, itchy, or teary eyes. So these are the common triggers: pollen, dust mites, or the animal danders. Okay. Other ways to diagnose allergic rhinitis includes the frequency and duration. Is it intermittent or persistent? Presence of other history of A2P, such as asthma or urticaria. Presence, again, of family history of A2P. Identification of possible allergens in home, school, or workplace. And whether there is a previous allergy testing, or what we call as the skin test. Okay. As what we have said, patients that are atopic have a low threshold for histamine, and the first line of management that we pediatric allergists or the allergists per se would give or offer to patients is oral antihistamine. Oral antihistamine. It relieves the bothersome symptoms of AR. We want second-generation antihistamine. It prevents and relieves the sneezing, itching, rhinorrhea that characterize the early response to allergen. And of course, we offer also intranasal corticosteroids. So antihistamine and intranasal corticosteroids are the mainstay treatment for allergic rhinitis. I must orient everybody with their antihistamine because the pediatrician allergists or on the medical field, we have what we call as the first generation and the second generation antihistamines. The first generation antihistamine, the most popular is diphenhydramine. And for the second generation antihistamines, what we have are fexofenadine, loratadine, desloratadine, and cetirizine. I'm sure most of us have heard of these medications or second gen antihistamine. Selecting a second-generation antihistamine, that is again loratadine, desloratadine, cetirizine, or fexofenadine, reduces the potential side effects that the first-generation antihistamine gives. So what are those side effects? Sedation, performance impairment, poor sleep quality, and the anticholinergic mediated symptoms. So the first generation antihistamines kasi they have this anticholinergic effect. So it will give the patient dry eyes, dry mouth, constipation, urinary hesitancy, and retention. Those are the effects that we do not want to experience or our child want to experience if we will offer the first generation antihistamine. Okay. Some would offer first generation antihistamine because they want to offer sedation. They want the patient to sleep. But usually there will be residual effects the following day. So we try to avoid giving first generation antihistamines. And efficacy is documented primarily with your second generation antihistamine plus the quality of life improvement. We also give intranasal antihistamine to patients with allergic rhinitis. So this is the intranasal antihistamine. So if you can see here, this is an example of your intranasal antihistamine. I am not a product endorser of this intranasal steroids, but this is what my daughter uses. Okay. So I will instruct to you how to use your intranasal steroids. So let's take this one. First is that you have to clean your nose. So this is what I always tell my patients. Clean your nose first prior to using your intranasal steroids. You can use your sodium chloride, or you can just use your there's something that you can buy in order to flush out all the debris inside your nose. And then when you are ready to use your intranasal steroids, so for example, this one. So you have to shake it, then remove the cap. And then what I always say, right, 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 left, left, left. So with my right hand, I do this. Okay, so my thumb, my index finger and my middle finger on top and my thumb at the bottom. And then my left index finger, I will press on my left nostril. Then the medication will go inside my right nostril and then will tilt towards the right ear. Okay, and then spray. One spray, or according to what the pediatrician or the allergist or the doctor have instructed. Then on the other side again, like that. Okay, so that is how you will use or you will instruct your children or your patients on using your intranasal steroids. Okay, next. Let us now go to another popular or common and potentially serious chronic disease, which is asthma. It imposes a substantial burden on patients, on the families, and also in the community. It causes respiratory symptoms. Sometimes it limits the activity of the asthmatic because of the flare-ups. So it requires urgent health care and it could be very fatal. It is very prevalent in the country with Filipino children. The prevalence rate is about 9.2% to 27.4%, according to the study of Dr. Varona, which is also a fellow allergist. So what are the common symptoms of patients having an asthma attack? They would have coughing, they would say that there is a wheeze, or yung other patients will describe it, Doktora, parang may pusa sa loob po ng anak ko. Ganon. That's how the parents would describe it. Then you would often see them using the accessory muscles here sa neck and the shoulders going up while breathing because there's difficulty in breathing. You will ask also whether there's a family history of A2P, and most especially if they have pets. So here are the common causes or triggers of asthma. The same with allergic rhinitis, the pet dander, the presence of pollens, the presence of dust mites, the presence of pollution. Okay. How do we diagnose asthma? Chest X-ray is not routinely done, but if there are recurrent wheeze or recurrence of attacks that is incompatible with the diagnosis of the pediatrician or the allergist or the doctor, if it is asthma, then chest X-ray may be valuable. And also, we also do, most of us pediatricians or allergists, we would require a patient to do a peak flow. The peak flow measures whether there is the degree of obstruction, airway obstruction of a patient having an asthma attack. So most of us allergies have a peak flow. Sometimes we will also request spirometry to measure the FEV1 or the lung function test of the patient. So peak flow and spirometry are the more objective measures whether to diagnose asthma. Okay. Next, we have come to diagnose asthma, but the next question is, how do we manage asthma? Asthma management has two phases: the treatment of the acute phase or the attack, which is actually the exacerbation, and second is establishing control to prevent recurrent exacerbations or recurrent attack. Therefore, management is divided into, as what I have said, acute management. Second, maintenance treatment. Third, patient education, preventive measures, and next is allergen immunotherapy. So the goal of treatment for the acute management is the rapid reversal of airway obstruction. And if there is hypoxemia or low oxygen levels in the blood, we have to correct it. The importance of early intervention should be emphasized on the parents, on the guardian, and on the older child. So initial therapy should be directed at assessing the reversibility of the airways. Okay, so what do we use? So I'm sure you have idea what to use in the acute phase of treatment. Okay. So as what I always say, whenever you see your patient having an attack, seek help. The longer it lasts, the worse it gets. The worse it gets, the longer it lasts. So there are two types of medications used for asthma. So they are classified whether the medication is a reliever or a controller. When you say reliever, it acts quickly. So it has to reverse whatever is happening to your child if there is an airway obstruction. The controller, just like some of the hypertensive parents here, that it controls the symptoms. It prevents further asthma attacks. Okay, so let us see what are those relievers and what are those controllers. So here on the topmost, we have here, I'm sure most of you are aware of this one. So this child is having his salbutamol inhaler. Salbutamol can also be in the form of nebule. There is also a salbutamol syrup. There's also a salbutamol tablet. Then we have here theophylline and terbutaline. I always explain to the patients or to the parents that the most common side effect of a patient on salbutamol will be a faster heartbeat, or what we call as tachycardia. Some would experience headache or muscle cramps. So the first part, the first 5 pictures, this is what we call as your relievers. It acts rapidly so that there will be a reversal of your airway obstruction or bronchoconstriction. The last pictures, this is what we call as your maintenance treatment. So maybe you are familiar with some of the maintenance treatment. What I have here are one brand. Again, I'm not an endorser of this brand. So this one, the purple one, this is the salmeterol plus fluticasone. So it is available in an MDI or a metered dose inhaler. And next, it is also available in the discus, in a discus form. There's another familiar maintenance is the red one. So that is the budesonide plus formoterol. Okay. So the aim of asthma management is to prevent exacerbation and asthma deaths, to relieve and control symptoms. That is why we always educate our patients. One thing that I always tell my patients, or the allergists tell their patients after using their maintenance treatment or this one, is that mouthwashing or gargling after inhalation of your steroids is effective for the prevention of local adverse effect. So we want to avoid the development of candidiasis and hoarseness. So that is why maybe you're wondering, bakit kaya pinagmumumog ni doktora yung anak ko after he or she uses the maintenance treatment? Because we want to prevent the development of candidiasis. Okay? Or oral thrush. It is also important for us to educate our patients as well as the parents and guardians. It is because of we want to increase their knowledge regarding asthma, prevention, and management. We want them to realize and to recognize what are the symptoms that their child is having an asthma attack. And most especially, most allergists will take time to demonstrate how to use the metered dose inhaler. So how to use this. So we also give an action plan to our patients, and we always try to identify with the parents or the guardians what are the possible triggers and the measures to avoid those triggers. For the preventive measures, we want the children to maintain a normal activity. So we do not want children to avoid physical education. We do not want them to be just stuck at home, watching TV, watching YouTube. So we want them to maintain a normal activity level, including exercise. We encourage them to always participate in those types of activities. We always help them to prevent recurrent exacerbations through asthma education. But sometimes the medication fails, or sometimes it is not enough, the use of your relievers, the use of your controllers. So the allergies will offer other treatment options. And that is what we call your allergen immunotherapy. Allergen-specific immunotherapy may be a treatment option where allergy plays a prominent role. So in the Philippines, the allergist offers allergen immunotherapy to patients. We offer allergen immunotherapy to our patients whom we are having difficulty in treating their asthma or their allergic rhinitis. So it starts first with the identification of the possible trigger. Then after that, we will begin our allergen immunotherapy, or what we call as your allergy shots. In here, this is my husband, who is an ophthalmologist. He is asthmatic and has allergic rhinitis. And he finds it very, very bothersome whenever he has allergic rhinitis attacks during OR, during operation. So I give him allergen immunotherapy. Okay. So next, this is the last part. So mga around 8 slides na lang po. So I'm sure many of you have questions regarding COVID-19 and asthma, and probably have read a lot about COVID-19 and asthma, especially if your children is asthmatic or if you are asthmatic yourself. So the question is, are people with asthma at increased risk of COVID-19 or severe COVID-19? The question is, it is not asthma that makes a patient or a person at risk of COVID-19, but it is the measures that we do and how to avoid getting sick that makes us at an increased risk of acquiring COVID-19. Systematic reviews have not shown an increased risk of severe COVID-19 in people with well-controlled mild to moderate asthma. Are people with asthma at increased risk of COVID-19 related death? That is another question. Overall, people with well-controlled asthma are not at an increased risk of COVID-19 related death. However, the risk of COVID-19 death was increased in people who had recently needed oral corticosteroids for their asthma and in hospitalized patients with severe asthma. So that means those patients who have a poor control with their asthma are at an increased risk. So what are the implications for asthma management? Have there been more asthma exacerbations during the pandemic? In 2020, when the pandemic began, many countries saw a reduction in asthma exacerbations and influenza-related illnesses. The reasons are not precisely known, but maybe because we always emphasize, or emphasis have been put to hand washing, putting on masks, social and physical distancing that reduce the incidence of respiratory infection, which is a common trigger for asthma. Now, it is recommended to avoid nebulizers whenever possible when your child or you are having an asthma attack to reduce the spreading of virus. What we recommend is the use of your pressurized meter dose inhaler, just like this. Okay, whenever there is an exacerbation that is happening. Okay, and inhaled corticosteroids used in those with asthma was associated with lower mortality. That is what they found out than in patients without an underlying respiratory condition. So it is important to manage your asthma properly during this time. The use of your maintenance treatment is strongly advised. Next question is, are COVID-19 vaccines safe in people with allergies? Yes, there are many types of COVID-19 vaccines, and they have all been studied extensively, and they have been used in patients with asthma. New evidence, including in people with asthma, will emerge over time. But in general, allergic reactions to vaccines are very rare. Therefore, they are generally safe in people with allergies. The Philippine Society of Asthma, Allergy, and Immunology, our society, have come up with guidelines in how to manage whenever there will be an allergic reaction to COVID vaccines. One example, one important question that must be asked during COVID-19 vaccination is that is there a history of allergy to any components of the vaccine, or if the patient has fever or another infection, or if the patient is immunocompromised. Those are the types of questions that must be asked prior to administering your COVID-19 vaccine. Okay. Lastly, okay. Okay. Lastly, it is recommended to have COVID-19 vaccination for people with asthma. Okay. Thank you, and that ends my lecture.